Ladies and gentlemen, welcome to this session entitled Maintaining Selective Coronary Access After TAVI and Redo TAVI Procedures. This session is sponsored by Boston Scientific, so thank you for their contribution. And really, I think we have a very exciting 60 minutes ahead for you. The objectives of this session are to understand the various challenges that we face when trying to get coronary access after TAVI, not just with an accurate neo, but with other systems. To learn different techniques for reaccessing the coronary arteries after TAVI, and also to discuss the various options for reaccessing coronaries after redo TAVI. I think this is a topic that is becoming much more to the fore and something that we're going to have to deal with in due course. While this system is all about coronary access after TAVI, that's not the main point of putting a heart valve in. Of course, the main point is acute procedural success, ensuring that we get a safe result, no paravalvular leak, no pacemaker, and good hemodynamics to give us a really good long-term outcome for the patient. So let's not get away from that. And as we go through the case that we're going to present and the live case, I would urge you to think about the accurate neo, not just in terms of a valve that gives us the added benefit of coronary access, but also a valve for most of your patients, really 99% of your patients, that can give you those other issues that are perhaps much more important. So let's start off with the case, Marek, and let's see what you guys treated in Poznan.
And maybe, and then we want to encourage everybody in the audience either to use the app to send questions on the cases you see or any question you have related to this topic, or you can also just go to the mic and ask the question there. So please, it would be fun if it would be interactive.
Okay, so I will show you what case presentation, what patient we will have. So here are my conflicts of interest. So we will have a 75-year-old male, typical patient with severe aortic stenosis with heart failure symptoms, NEHA class 3, and some chest pains, admitted for the hospital for TAVI. That patient is with long history of hypertension, diabetes, and also patients with paroxysmal atrial fibrillation on DOACs. As you can see on echo examination, there is no doubt that there is a significant stenosis. The mean gradient is 65 Vmax, you can see, and AVA is 0.7 square centimeters with quite good ejection fraction. BNP just confirming that is a severe stenosis. Moreover, that patient on May 2022 had acute coronary syndrome, so it was an acute MI without ST segment elevation, and aortic valve stenosis was diagnosed first at that time. And you can see the coronary angiogram, which was done at that time. And in that coronary angiogram, you can see that there are two tight stenosis. There were two tight stenosis, one in LAD and one in obtuse marginal branch. And these, let's say, stenosis were fixed with two drug-eluting stents, which one was put to the LAD, the other one was put to the circumflex. And at that time, there was a CT examination, and that CT examination showed exactly what kind of patient it is. And it's a patient with perimeter, annulus aortic perimeter of, as I can see here, of almost 82, LVOT exactly almost the same, quite good height of both left and right coronary access, ST junction of 30, and sinuses of Valsalva were not narrow at all. And there were huge, and as you will see in a second, huge aortic calcification. You can see a careful analysis of the annulus dimensions also just here. And these huge calcifications of the aortic valves could be visible also here. However, the access to the femoral arteries was quite normal. So for us, there was a decision to perform TAVI with the accurate. We may, of course, discuss why with accurate, but our main concern here in that patient was to have preserved access to coronary arteries for the potential future interventions. Thank you.
Thanks, Marek. So as Magnus is getting ready, let's ask you a couple of questions about the case. Did you consider surgery maybe in this patient?
No, in fact, we were not considering surgery in that patient. That patient is, I would say, on the borderline with age. However, there was, of course, discussion with my cardiac surgeons who are sitting here in the room, and there was no option for that patient. We believe that TAVI is a better option for that patient.
Okay, and we saw quite significant calcium on that valve. I don't know what the volume was or the Agascon units, but a lot of people with that kind of calcium would suggest that the accurate neo doesn't have the radial force to open this valve. Maybe you should take a balloon expandable valve, or maybe you should consider taking an Evolut. What were the factors that weighed in terms of your decision-making process?
Yeah, to tell the truth, at the beginning, I also thought that Accurate is not the best valve for the huge calcifications. But with the experience with balloon pre-dilatation, which we are doing in every case, I think that valve could be used also in patients with quite high calcification as in that patient.
Okay, so you're using this routine valve really irrespective of the severity of calcification in your practice?
Yeah, exactly.
Okay. Magnus, this is a case really where we want to maintain coronary access. It's important to Marek and his team, given the coronary disease that this patient has. What are the difficulties that we have with coronary access after TAVI?
Yeah, I will spend a couple of minutes describing these possible issues that we might have following a TAVI when it comes to coronary access. These are my conflicts of interest. So first of all, the need for coronary access. So is there actually a need when after a TAVI procedure? Well, if you have a pre-existing coronary artery disease, the likelihood that you will be needing a coronary angiogram is actually quite high. And this is so we cannot ignore this problem, especially in patients with coexisting coronary artery disease and also in younger patients. So what are then the predictors for an unsuccessful coronary angiogram? Well, the classical risk factors are depth of the implant, but also the design of the TAVI valve. Just recently, in addition to this, Tarantino and co-workers also could show that especially for supraannular valves, maybe the misalignment of the valve is probably the most important predictor for an impaired coronary access following TAVI. So that's why I think it's very important in 2022, you should always try to do commissural alignment when performing your index procedure with your transcatheter heart valve. So you will see how that is done with the Accurate valve following my talk here during this session. But these are then results from our group where we could then show that commissural alignment with the Accurate valve could be performed in a safe and effective way, and also, quite importantly, with very low added time to the procedure. So in this time, 92 seconds was added to the procedure to perform commissural alignment. You also have to bear in mind that commissural alignment is not only important for coronary access, it's probably also important for coronary artery flow, for sealing, for durability, and also for future TAV in TAV procedures. So TAV in TAV procedures is still a very rare phenomenon. Its incidence is well below 1%, but when it's performed, it has actually been shown to be a quite safe and effective procedure with low residual gradients, low risk for coronary flow obstruction, and also a fairly low 30-day mortality. However, in order to also make sure that these very acute good results is also are transformed into good long-term results, there are several things that we need to take into considerations when choosing our second valve for a TAV and TAV procedure. And that is, of course, what is the height of the neo skirt that we are producing with our second valve? What is the size of the cells that we have to access the coronary arteries? And also, is there a risk that my second valve is now misaligned and the frames of the second and first valve are now impairing my coronary access? These are some of the problems that we encounter when doing a TAV and TAV procedure, and then for future coronary access that we will discuss more in detail during this session.
Thanks, Magnus. If I can ask you a couple of questions, maybe.
Sure.
Commissural alignment seems to be relatively straightforward with the NEO. Do you do it in every case in your center?
Yeah, so this is done now in every case, actually.
Okay.
Yeah.
And are there any risks with doing it? I mean, rotating a valve within a stenotic aortic route, lots of calcium around. Sometimes in the past, you cross the valve, the patient becomes hemodynamically unstable. What's your experience with that?
So my experience is this is usually not the case. I mean, you can, as we all know, we can encounter problems just by putting the valve into the aortic annulus. So this can, in these situations, we can encounter hemodynamic problems. But we have not seen that performing commissural alignment with the accurate valve adds risk to the procedure. And I think also does not add time, honestly. It's a really simple, straightforward, just follow the rule book kind of procedure, actually.
Okay. Ole, can we do commissural alignment with every system that's commercially available today, or what systems can we do it with, and what systems can we not do it with?
Yeah, well, I mean, there is a lot of investigation still in that field, I would say. Balloon expandable, it's difficult because there's no way to assess it before the valve is completely deployed. So that I would say balloon expandable is a hard time to do that, or impossible. Then with the self-expanding valves, you have a possibility to open and look where the posts are, but for example on an Evolut there are no posts visible, so there you have to look to the head marker on the delivery system. It's a limitation of the current Evolut system we have in Europe is that it's also not, you cannot rotate it, it's very stiff, there's a spine in the delivery system. So, but you, with some tips and tricks, 3 o'clock with the flush port, etc., you can minimize commissural misalignment, but not in that degree as with an accurate. So clearly we did a study, a comparative study. Accurate was best in class for sure. We could avoid 100% the moderate or severe commissural misalignment. So that's the most important. Portico Navitor, there are posts visible, but they are hard to visualize in obese patients, for example. So it's not easy. It's possible to torque the catheter, but it should be optimized for future generations of the valve. So that's where we are. I think it's also really essential that these valves, they can be rotated and aligned with commissures when you have it in the ascending aorta. Because there's quite some techniques described where you go in a certain direction, orientation, rotation with your valve in the descending aorta, but still this aortic arch is not a 180-degree nice arch. There is a lot of 3D rotation also often in these arches. So these techniques, we have been doing these techniques also with other valves, also with the Accurate, to see if it was possible, and actually the conclusion was it's a failure. I mean, it was not successful.
Okay. Arif, we've got a few moments. What are the features of other valves that lend them difficult towards coronary access after TAVI?
Yeah, so I think the basic principles are, we're putting a metallic stent frame which has a combination of tissue and metal in the middle of an aorta, and all our techniques and catheters, which we've been taught right from the 50s and 60s when these were invented, were designed not to have something in the middle. So we've got multiple barriers. So with supraannular valves, we've got tall stent frames, a lot of metal blocking. All the valves will have commissural posts, which can also block. And then you've also got the leaflets, which in the case of supraannular are just higher up and therefore closer to your catheter. And in addition, every valve comes with a pericardial skirt frame, which is basically an area which is inaccessible and you cannot traverse the valve frame through that. So these are the four things that are common to all TAVI valves.
Okay.
But I think it's really important because if we talk, for example, about accurate, it's a tall stand frame, we say. But to me, as an operator, it's of course there is a tall stand frame, but I don't see it as it's a tall stand frame valve, because it's almost, you just have this lower dense nitinol part, which is at the calcified leaflets with the upper crown, but everything above it, it's a complete open architecture. So that's advantageous because it keeps the leaflets there. But I think this is essential. We call it a tall stand frame valve, but in a way, if we talk especially about coronary access, it's to me a short stand frame valve, to be honest.
So we've got a moment. Why don't we ask Arif to bring up the design of the valve, and if we can show the smart screen, please. Again, we have wide open space here to get catheters in and to be able to access the coronaries. Can we bring up the smart screen? Thank you. Arif?
Yeah, so there's a couple of points to point out with the Accurate Neo. First, when we're talking about some of the challenges, and as I mentioned, there's things which are common to all valve frames, and you've got them in the Accurate Neo as well. You've got this concept that I said, this is the pericardial skirt, which is covered, so it's an area which is inaccessible. You've got the elements of the commissural posts, which are here, which can all interact with your catheter. And then you've got the fact that there is metal which is coming to a higher distance. But if I come over to the other side, and just to show you why the Accurate is actually a beneficial valve in terms of coronary access, you can see that, number one, the fact that you see the post, and we'll see later on fluoroscopy, you can achieve alignment very regularly. You've got these large open cells which essentially give you a sort of a window, particularly when you align the valves. You essentially create a window directly in front of your coronary artery to achieve access. And then indeed, as Ollie was just mentioning, although this is classified as a supraannular valve, in fact, you've got this split level design whereby you've got the short lower stent frame and then a relatively open and a free structure just above that.
Okay, thanks, Arif. That's great. So again, a good valve for coronary access post, but let's face it, coronary access is a bonus. It's a good bonus, but it's a bonus. Let's see then perhaps how you guys got on in this heavily calcified anatomy, this hostile anatomy, and see can this valve do the other things that we need it to do. So maybe we might play this live case. It's about 15 minutes, and then we can take some questions afterwards.
I'd like to welcome you from the Poznan University Hospital. We are just before the TAVI case, in which we would like to show you how the TAVI case with commissural alignment with the Accurate valve should be performed. We are working in a team. My name is Marek Grygiel. I'm an interventional cardiologist working together with my friend cardiac surgeon Marcin Misterski, with anesthesiologist Paweł Marcinkowski and echo team, nurses and technicians. Okay, so we have started to work already. On the left side, there is a 6 French femoral artery sheet and femoral vein sheet. From the femoral artery, there is a pictate catheter. From the vein for the temporal pacemaker, we decided to use it like that, not over the wire on the right side, because that patient has a sick sinus syndrome with significant bradycardia, so we decided to use a lead which we will maintain at least for 24 hours after procedure. And on the right side, there is also the right femoral artery, and through which we inserted an eye sleeve sheet. And now we will inject for the first time a contrast, just to see how the aortic valve complex looks like, and it looks like that we are in the line, and that patient has not only, as you can see, stenosis, but also some regurgitation. And we are we will try to cross the valve. Our first approach is Amplatz left 1, and with that guide wire we will try to cross, and as you can see, it was quite easy, because that time it took me only about 15 seconds. Our usual approach is that after crossing the valve with a straight guide wire, we exchange it to the J-shaped wire and introduce a pictate catheter. We believe that it's safer to exchange to the stiff guide wire over the pictate catheter. Moreover, we use that catheter to assess gradients before and after the valve implantation. So now you can see the pressure curves, the blue one in the ventricle, the red one in the aorta. So there is a significant gradient of almost peak to peak, almost 100. So that confirms that it's really significant aortic valve stenosis. And now we will introduce a sapphire wire, which is our preferred wire, sapphire small wire, which is our preferred wire for the accurate implantation, which we use in 95%, I would even say 99% of the cases, just to have a good support during valve implantation. Sapphire wire is in the ventricle. I think that it's important to mention here that it's with that valve system with accurate Neo2, it's quite important that wire should be on the outer curvature and sitting quite deep in the ventricle to have an adequate support for the valve implantation. And as you have noticed, we have also a balloon which is just above the aortic valve. And we plan to implant an accurate Neo2L size valve. And we decided to use a 25 balloon for the pre-dilatation. And we, with accurate Neo, we are performing pre-dilatation in almost 100% of the cases. And now during fast ventricular pacing, and let's start stimulation, we will perform a balloon pre-dilatation. As you can see, the balloon is quite stable and deflate.
Pacing up.
And stop stimulation. And we are removing the balloon. In the meantime, the valve was prepared, and we are ready to insert that valve. However, since we would like to obtain commissural alignment, the crucial point for that during insertion of the delivery system is, let's look at the distal part, just to insert the system with that safety button at 6 o'clock, 6 p.m. We know from the studies that it enables and helps in obtaining the proper commissural alignment, which in that case is quite crucial. As you have heard, that patient is after previous coronary intervention on 2 arteries, so it would be quite important to get to have access to the coronary arteries in the future. And now we are inserting, and let's now focus just here on my hand, and we are introducing the valve to the sheath. At the beginning, you may feel some resistance. And all the time we are confirming that the wire is inside the ventricle. So we have passed and went out through the eye sleeve. And now let's maybe move a little bit and show the arch. And with that valve, as you can see, it's quite easy to cross the valve. And for the obtaining the commissural alignment, we have just moved, and we have to go over the valve, and we will start just here. And now, as you can see, we have a configuration 2-to-1. So there is a wing or free cell on the right side of the screen. So we have to make a clockwise rotation in the free cusp view to have free pose in a proper orientation. And moreover, we need 2 wings on both sides. And I think that now we have them on both sides. Okay. After that maneuver, we have to release tension, as you can see here, just checking all the time if these 2 wings are on both sides. Yeah. And after that, we knew that we are properly oriented in free cusp view, but now that pose which is in the middle, maybe in front or at the back. Just to confirm if we are in a proper orientation, we have to move the X-ray lamp to a cusp overlap view, and let's do it now. And if the orientation is proper, on the two-cusp view, that wing or free cell should be only on the right side, of the screen. And as you can see here, it's just on the right side of the screen, so there is a proper orientation. And what is now important for the implantation, you come back again to the free cusp view, and the whole implantation process is in the free cusp view, and you are just confirming if these two wings are still on the both sides, and now you forget about the commisural alignment. Now you concentrate on the proper depth of the valve. We are moving forward to the desired position, and the desired position is a marker on the delivery system which should be at the down level of the pigtail. I think that's something like that. And now let's inject contrast to check if we are in the desired and proper position. We will start to open the upper crown. And the valve, as you can see, it's stable. And we will move forward to achieve the opening of the stabilization arches. As you can see, there is no blood pressure drop, no movement of the valve. I will record it once again. It's a full stop, Marcin?
Yes, it is full stop.
Yeah, so we will inject contrast once again just to confirm if we are in a proper spot. So we will now remove the pigtail. And just a second. And during recording, we will implant the valve. And as you can see, the valve is implanted. However, as you can see, the stand holder looks like that it's still attached to the frame, but however, it's not a big deal. We will just remove a guide wire slowly, and it will, I hope it will.
It's already detached.
It's already detached, as you can see, and just to remove the stand holder, come back with the wire even more, come back with the wire even more. And now we are removing the stand holder from the valve. Okay, stop. And now we have to close the whole system and look at the hands. And just to be ready, first number 2, then number 1. When coming back with number 1, you have to remember that the guide wire is getting out of the ventricle, and we are in a perfect position, and we are removing the whole system out. Also, the diastolic pressure of that patient is quite normal. It's 56. However, on angio there was some leak, and due to the high calcification, that valve is not fully expanded, so we decided to perform a post-dilatation with the same balloon, so it's 25 balloon. And so if we can start fast pacing again, and it's 180, and we will now try to end balloon start, and we will go ahead with a balloon inflation. And you can see that we obtained a better post-dilatation of the frame of the valve and stop stimulation. And we will remove the balloon once again and assess the valve once again. After valve post-dilatation, you can see that the pressure curves showed a nice separation of diastolic pressure in the aorta in the left ventricle. So on echo, there is just trace aortic regurgitation. I am removing a pigtail from the ventricle and will just for the confirmation, just inject contrast once again, and you can see that there is nothing or maybe trace aortic regurgitation. So very good hemodynamic result of that accurate neo2 implantation. And now at the end, just for the confirmation that we achieved a proper commissural alignment, just in our FreeCASP view, you have a free poles well separated. And we are now going to the CAS overlap view. And in the CAS overlap view, which I just now recorded, you can see that we have also a quite good and proper orientation. And we will try now with a standard catheter just to get into the coronary artery. And now, as you can see, it was quite easy. It took me 15 seconds to get in. So, and I believe that I am in the left main. Yes, I am in the left main. And let's go to the AP cranial view. And with the AP cranial view, another contrast injection. So you can see that it's quite easy, and I think that even for the operator who is not involved in the TAVI procedure, when he will be on duty, getting to the coronary arteries should be not a big deal. And also getting to the right coronary artery was not a big deal, and I believe that I am in. And let's move to the other projection. So you can see that that result is quite good, and with the access to the coronary arteries with the proper commissural alignment, it's not a big deal. So Marcin, I think I'd like to thank you from the Poznań University Hospital. We hope that case was interesting. Thank you very much, and thank you for the whole team here in the cath lab. Thank you.
So, Marek, fantastic case, congratulations. A couple of questions. First thing, how did you decide on the pre-dilatation balloon? So it seems that we pre-dilatate always with the Accurate Neo2 because it doesn't have the opening force, but it does have, once it's open, the same radial force as many other systems. But are you more aggressive? Are you less aggressive with your pre-dilatation?
Yeah, it's an excellent question. Yesterday, Ole with Lars showed a case, and in Copenhagen, I have noticed that they are, let's say, less aggressive with the pre-dilatation. We are with Accurate very aggressive with pre-dilatation. So usually 1 millimeter smaller balloon than the perimeter derived. So it's a quite, I would say, aggressive pre-dilatation. And so far, we have no problems with that pre-dilatation.
And Ole, I know that from yesterday's case, you guys tend to respect the minor axis of the LVOT or the sinotubular junction, whichever is smaller.
Look, that size of that balloon, first of all, depends what kind of balloon is it. We use true dilatation balloon. This is a non-compliant balloon. So if you take in 20, it goes really up to 20. If you take a 20 semi-compliant, it goes maybe up to 18, 19. That's already a small difference. And then I think indeed we try to respect the minor axis of the annulus. On the other hand, if it's very calcified, there's a lot of different things that influence the size. It's calcification, is there an RBBB up front, yes or no? I mean, then we're going to be more restrictive in our size. If there's no ECG, bundle branches and blocks, and there's a very heavy calcification, we're going to go a little bit higher, even up to the perimeter derived -1 or 2 millimeter as well. So,
yeah. I mean, we saw a very calcified valve, a mean gradient of 100. I mean, that's as bad as it gets.
So that justified a more aggressive pre-dilatation.
And also not surprising that you're going to post-dilate with any system. Magnus, if I can come to you, pacemaker rates with this system. In the region of about 7, 8, 9%. Yeah. Do we try and get this system higher to get lower pacemaker rates?
No, we need to know that this valve needs to be put in the same position every time. So there is no benefit of having a high position. There is only drawbacks by that. So if you try to put it even higher, then the risk of embolization, especially in a case like this where you have a heavily calcified valve, then there's a very increased risk for embolization. And I just need to point that out, because you also mentioned that the stent holder did not drop immediately. And this is also something that we see in heavily calcified valves. And I just need to point out that if you see that, just wait. Usually it drops by itself, and then you can continue. But another thing as well is then when you withdraw your delivery system, go to your cusp overlap view, because sometimes you have a severely underexpanded stent in that view, and you could actually then unintentionally pull your system out with the delivery system. So
because the cusp overlap really is the short axis of the aortic valve. So if it's going to be constrained, it's going to be constrained in that view. So I think that's important in this type of anatomy. Marek, you took some extra precautions there with this patient. In terms, you put a temporary wire in. You didn't paste on the wire. You said you were going to keep the patient on telemetry for 24, 48 hours. Your experience in terms of patients getting home after this system, are you waiting a couple of days to see if pacing issues arise, or if it's not there immediately after the procedure, you tend to move them home?
Yeah, I would say that with that system, we are staying on the safe side. With other, let's say, self-expanding systems, we are expecting much more conduction disturbances. With Accurate, it's extremely rare, as Magnus mentioned. So, however, in that patient, as I mentioned, it was a sinus bradycardia, and we were afraid that maybe that patient would need a pacemaker. Later on, there was an excellent outcome, no need for the pacemaker, and the patient was discharged on day 3 from the hospital with good hemodynamics, no PVL, so an excellent result.
I agree, Darren. I've never seen late conduction disturbance. That was your question. I've never seen it. I think it's thanks to the fact that the upper crown holds it back from deep implantations. Yeah. We aim for the nominal implant, which is around 5 to 7, but it never comes lower, or you have a bad implantation, of course, then. And also, it's a straight stent frame. So I've never seen, to be honest, really, a late conduction disturbance.
Yeah, the same. And that's why, we tend to get patients home that little bit quicker with Accurate rather than other systems, but which can continue to expand. Arif, while you're going to move over towards the smart screen, I wanted to ask about the issue of TAV and TAV again, Ole. Are there specific advantages to this system with respect to TAV and TAV, particularly when the commissures have been aligned, like we saw in the case from Marek?
I mean, really, absolutely. We have been doing, and that's Arif has been doing great work. Janar as well from Vancouver. They have been doing great work in this TAV and TAV, seeing which combination is the best and how it impacts the coronary access. I think really, honestly, unbiased, I say this, that if you put an Accurate as the first valve, and even more so if you do it with commissural alignment in your patients, you have to do a really bad job with your second valve to get problems with the coronary access. And I think Arif, he can maybe make a drawing on there. There's a lot of bench testing been done there, and that looks extremely promising. Yeah.
Okay, so Arif, maybe before we do that, you might take us through some of the issues that you guys have seen in your work with accessing the coronaries. What are the fundamental obstacles?
Yeah, thank you. So we had this unique opportunity whereby we took Marek's case into the simulation lab and sort of 3D printed the exact model, put the valve exactly how you put the valve, and then basically played with many different catheters to try to understand some of the challenges that we had. And so just to highlight some of the things, as you can see on the left-hand panel, what you see, if you look at in the bottom circle just over here, is you can see this is in diastole. And what we have in diastole is you can see an opening which would lead to aortic regurgitation. And indeed, we've even put hemodynamic traces into this model, and you do see a drop in aortic pressure. So one of the things to highlight is that sometimes if you're in the middle of, let's say, a complex PCI and you're getting a drop in your pressures, just think, particularly when you're using a supraannular valve, particularly if you're using a supportive catheter such as an EBU or an Amplatz guiding catheter, that you may be impinging upon the leaflets, and that's what it can look like. Other things that we notice when we're trying to rotate within the valve frame, you keep coming to and obstructing and hitting some of the commissural posts, and you can see that over here. We were trying to rotate, and it's again just a matter to be noted that if you're rotating and you're not seeing that one-to-one movement on your catheter, just be aware, because fluoroscopically it might not be so obvious, but you might be hitting one of the posts. And then we come to the side here, and again, it's just just an awareness again that our leaflets are actually a little bit higher than you'd think. So sometimes your catheter, you might think you're clear of the stent frame, but actually you're still underneath and within below the supraannular valve leaflets. Now something, however, which was quite interesting, I mean, you can see, and I think this is quite relevant, mentioning the point of choosing your catheter carefully, depending on the valve and the challenge that you have. We have, again, the same anatomy, which is Marek's case. We have the same views, everything, but we've got a big difference in how much the leaflets are open with subsequent regurgitation, and that's simply using a Judkins left 4 catheter on the left-hand side and an Amplatz catheter. Both are in the same position, as you can see, fluoroscopically. It's a very subtle difference, which you might not be able to tell. One's more horizontal, one's a bit more vertical. One is not going to give you problems. One will give you problems. The last thing just to mention, actually, we did something which is quite interesting. So Marek, and I have a question for you here. When you did the cannulation of the left coronary artery, I saw that you'd had all the wires pulled back. So then you had to put the wire back down. Now, that's your cannulation. We, in the lab, replicated the exact fluoroscopic angles, implantation depths, and everything. And I put it to all of you that, as you can see over here, the 2 fluoroscopic views and the positioning of the catheters look, I would say, almost identical. Very difficult to tell what's happening. But if you look lower down in the screens here, you can see that we've got a very different cannulation approach. So what we've got in the middle is we've got our more conventional internal approach. So if our wire was in the left ventricle and we simply fed the catheter over the wire, we'd be internal within the valve frame. And what we had on the right is actually, you can see here, it's completely bypassing the valve frame and going outside. And this is actually one of the advantages of the accurate neo-valve platform, that you have different access routes, both internal or external, which can sometimes be beneficial. And actually, we did a study blindedly where we got operators to fluoroscopically only perform cannulations, and it was about 1/3, up to 1/3 to 40%. They were going external without knowing. So I think that's quite a good benefit.
Thanks, Arif. So in essence, you can cannulate inside or outside the frame of the accurate. The choice is yours because those cells are so wide open. And so whether you go outside or inside really doesn't make any difference. You can still cannulate selectively in Ole's data 100% of cases. And that extra space around the outside, because of the absence of the frame, that's, I think, the advantage that we're going to see in TAV in the future.
Exactly, that's the thing. If we talk then about the second valve being a balloon expandable short frame stent, if you put this at the top, the outflow part, together with the upper crown, in fact, you preserve all these beneficial aspects and you maintain that easy coronary access. So you don't compromise on that coronary access despite that you ended up in a scenario of a TAV in TAV. So that's the beauty of it, I think. Yes.
Arif, you can show us maybe that access in TAV and TAV.
So we went one step further and went into the lifetime management journey for this patient. So we put a balloon expandable valve inside the accurate valve in your patient. And as you can see here, we maintained good selective supportive coronary access, both for the right and the left coronary artery. And we were able to perform both diagnostic angiography and PCI. But one of the other things I just want to highlight, which is really the discussions and the questions that we have, in this particular patient in your anatomy, we could put the balloon expandable valve low, or we could put it in a so-called higher position. And actually, in both cases, we achieved good, selective, straightforward coronary access. So that's a good thing in terms of the accurate neo platform. One thing just to point out, as you can all see, is that there's a big difference in how the accurate neo leaflets behave. You get what we're now describing as leaflet overhang, and you get a lot more leaflet overhang in configuration A with your balloon expandable low, and less leaflet overhang in the second configuration. And that's something that obviously needs to be worked on.
Thanks, Arif. So I hope over the last 45 minutes that we've shown you that the Accurate Neo 2 is a valve for all seasons. It's not just a valve for selected cases of mild calcification or moderate calcification. We've seen a heavily calcified valve treated with commissural alignment, a patient at risk of pacemaker who did not end up with no paravalvular leak, and to the best of our knowledge, we have perfect selective coronary access, and we maintain the option of TAVI and TAVI for younger patients in due course. So with that, I'd like to thank Boston Scientific for sponsoring the session. I'd like to thank Magnus, Ole, Arif, Marek, and Andrew McNeese, our chat master. Thank you all for coming, and enjoy the rest of the meeting.